giving you a little bit of an overview of a chapter that I helped piece together on the story of Pgta. Yeah, really honored to be in such star-studded company. So really, thank you so much to everyone for having me. So what I'm going to try to do is just walk you through the chapter that we wrote in a very, very abbreviated way, starting off with just a brief history, then an overview of Pgta, where we are today, a little bit on aneuploidy and mosaicism, and then I'll gloss over prospects of non-invasive Pgta. So just jumping right into it. So pre-implantation genetic testing for aneuploidy is essentially testing embryos in an effort to determine their ploidy status. It's used for different purposes, but notably to screen for aneuploidies that can lead to the birth of babies with chromosomal copy number syndromes, also to reduce miscarriage rates, since almost half of first trimester abortions are due to chromosomal aberrations. And it's also utilized with the intention of improving IVF outcomes. So for example, reducing the time to pregnancy. And kind of note of PGTs, or of the different pre-implantation genetic testing applications, testing for aneuploidy is the most prominent, but also one of the most controversial. So global figures are kind of hard to come by for Pgta, but over the past, I'd say 20 years or so, it's been estimated at least that there's been over 100,000 Pgt cycles. And of those, about 80% of them were Pgt for aneuploidy. And there appears to be this increasing demand each year. So a very brief history of Pgta. Where did this all come from? Where did it start? And the first example of Pgt was in rabbits by the detection of Barr bodies, which is a way of sexing rabbit embryos. It was first applied in humans using PCR for Y-specific repeat sequences. So again, this was for sexing, with the idea being able to control for X-linked conditions by just transferring female embryos. And it was soon replaced by fish, so using probes for X and Y. And then additional chromosomes were added, so specifically those that are associated with live-born syndromes and considered high risk. And then, yeah, so clearly with the intention, I guess, of reducing the risk of offspring with these live-born syndromes. And then they started adding, there was chromosomes that were added that are associated with spontaneous abortion, so like 16 and 22, again, in order to deselect these embryos for transfer. So this might not seem like a big deal, but in my mind, it really constitutes kind of a seminal shift in the use of aneuploidy screening. So basically, we're shifting from harnessing this technology to reduce disease and conditions that can persist until birth, and kind of broadening its application with the intention of improving IVF outcomes by, for example, reducing the risk of miscarriage. So what that means is today, the main referral categories are then recurrent miscarriage, recurrent implantation failure, advanced maternal age, severe male factor, all of which are associated with increased aneuploidy. And then thanks to breakthroughs in IVF culture conditions, vitrification, and molecular genetics, there's been lots of refinement in the Pgta process kind of over the years. And now we have platforms that can screen for all 24 chromosomes, as Darren already spoke to, but these platforms have this increased resolution. So now we're able to kind of see things that we couldn't necessarily easily visualize before. And I'll talk to that a little bit further on. But I just want to have a quick comment on all of the controversy. So why isn't Pgta universally embraced? And this is obviously a very loaded topic, but I think it's important to remember a few things. One being Pgtm, so pre-implantation genetic testing for heritable diseases or monogenic disorders, has been credited with the birth of thousands of unaffected children, and rightly so. But its benefits are really tangibly measurable. And then, of course, in walks Pgta. So there's a good number of studies that attest to its efficacy. There's retrospective analysis, RCTs, non-selection trials, you name it, all of which attract criticism for something. So sample size, study design, interpretation. And then there's the STAR trial, which is one of the most prominent and highly anticipated studies, which really provided ammunition for both proponents and opponents of Pgta. So it showed no significant increase in improving first-time pregnancy rates between cycles that did and did not include Pgta as part of their treatment. But when you go back and kind of reanalyze that data, you see a significant improvement in pregnancy rates for women over 35. So yeah, there's a few other technical and procedural issues with that study that may have confounded the data in some way. So, but again, I think some of the potential benefits of Pgta are not appropriately quantified and really often overlooked. So we're not talking about prevention of disease by inheritance. We're talking about less tangible things, like maximizing implantation potential and addressing patient-specific needs, like a patient's anxiety over the prospects of experiencing another miscarriage or maybe another failed transfer, or offering a couple some peace of mind of having genetically competent embryos banked for future use. So with that, I'm going to kind of move into the next section, which is just Pgta in a nutshell. I'll kind of give you some highlights on some of the technological advancements. So starting with sampling methods. So Pgta, at least in its current widely embraced form, requires genetic material by which to perform analysis on. So typically biopsy of some kind, so be that polar body, blastomere from cleavage stage embryo, or trifecta biopsy from a blastocyst. In the interest of time, I'm just going to speak to the current most popular method, which is blastocyst biopsy. I'll just play this video for you and I'll kind of talk over it. But so for starters, improvements in IVF culture conditions has led to higher blastulation rates in vitro and really opened the door to routine blastocyst biopsy, along with improvements in vitrification methods. But more specifically, a blastocyst typically has 100 cells or so, and removing somewhere between 2 and 10 of these cells is less likely to have an adverse effect on future embryo development, since it means removing a smaller proportion of cells to embryo when compared with like a cleavage stage biopsy, for example. It means more cells or more genetic material by which to perform testing. So this typically translates into fewer amplification failures, a lower chance of misdiagnosis, and allele dropout. Also, we know that chromosomal mosaicism is lower in blastocysts when compared to their cleavage stage counterparts. And also notably, it reduces the cost of Pgta since there's fewer embryos that require biopsy, since fewer embryos will reach the blast stage due to attrition. So, okay, back to after we do that biopsy, whichever kind it is, you take your biopsy genetic material, you can either fix it to a slide or load it into a tube and subject it to some form of amplification, be that whole genome or targeted genome or quantitative PCR. Then different tools can be utilized for actual analysis. So I could get into the good, the bad, the ugly of each of these, but I'm just going to really gloss over this. You've already seen the slide once today. But basically, we've gone through many iterations in technology. So FISH, array CGH, NGS, SNP-chip, carrier mapping, quantitative PCR, and a lot of these are still in use. But currently, the most popular is NGS, or next generation sequencing, and it's really become the workhorse of modern PGT. So these platforms, and specifically NGS, offers a significantly higher resolution. So meaning we can visualize our trifecta biopsy or the cells that we load into our tube more deeply. So essentially examine them with a higher power microscope. And we can see things like mosaicism or segmental aneuploidies. So just to give you a visual of what a cohort of cells that are of mixed karyotype, so mosaicism might look like. On the left, you see a fully euploid biopsy result, and there's 2 copies of all 22 autosomes and 2 copies of X, so that's a normal female. In the center, you see an abnormal male sample with a monosomy at chromosome 16. And then on the right, you see kind of an intermediate result where we can kind of deduce or we suspect that of the cells that were biopsied, maybe around 25% of them or so contain a monosomy in chromosome 2, and the remaining cells were euploid. And because of this higher resolution, small segmental gains and losses or subchromosomal aberrations, so not just whole chromosome or full chromosomal issues, can also be picked up in some cases. So these may have been overlooked with previous platforms that couldn't look at genetic material with this level of magnification. So I think that this is all very exciting, and these advances in technology are really shedding light on issues like mosaicism and segmental abnormalities and their prevalence in advanced human embryos. And we're really learning more each day. But with it, of course, it's kind of ushered in a whole host of other questions and issues that need tackling. So to me, it's kind of, I live in San Francisco, and the fog, especially in these summer months, it just feels kind of analogous to this whole thing. So as soon as you think the fog is clearing up, it just rolls right back in again. So these technological advances in PGTA have offered us lots of clarity into the human blast, but we pretty quickly find ourselves back in the dark trying to tackle all these new questions that they present. So what do we do with this additional information? You know, how do we manage it clinically, or what does it all mean? Next I'm going to, I guess, not really address those questions here, but I'm going to move right into our next section, which is aneuploidy and mosaicism. Just kind of what we know. So this is a small diorama of a euploid embryo. So we see a normal complement of chromosomes in each of the cells. Here we see a uniformly aneuploid embryo, which has extra or missing chromosomes in all cells, but such that all cells are karyotypically concordant to one another. And this also includes embryos with uniform segmental aneuploidies. Then we have a cartoon here of a mosaic embryo, which contains 2 or more chromosomally distinct cell populations in an embryo or a fetus, so including the placenta. So it could contain, you know, a euploid and aneuploid cell lines, or 2 aneuploid cell lines that are not concordant, and so on. So aneuploidy, the headlines, it's aneuploidy is the leading cause of mental retardation in humans. It's the leading cause of pregnancy loss, a leading cause of obstetric complications like IUGR. It can lead to imprinting syndromes through UPD. It's a leading cause of infertility, and a leading cause of repeated IVF failure. So it seems like aneuploidy is bad, and we should kind of do what we can to deselect aneuploid embryos for transfer in an IVF cycle. However, like most things, is it really that simple? You know, what about mosaicism? So mosaicism in human IVF embryos, what do we know? So we know it was first detected in humans by fish in 1991 by Professor Griven. So obviously your previous speaker and also one of your moderators, so feel free to direct all questions to him. I would love to kind of have the time to review all the literature on the incidence of mosaicism, but that's really for another day, or feel free to read the book. But basically all studies kind of say something slightly different. But there are some suggestions out there that mosaicism rates vary between IVF clinics. And if this is true, we need to evaluate culture conditions, biopsy techniques, etc. And the incidence of mosaicism also depends on the Pgta platform that's used, and the thresholds that are being used to define mosaicism. The implantation potential of mosaic embryos depends on the timing of the segregational error. It also depends on the proportion and lineage of the affected cells. So, for example, could the aneuploid cells be confined just to the trifecta, and also the type of abnormalities and the chromosomes involved. So how does aneuploidy and mosaicism arise? There's kind of an endless list here. I know I'm sure you're all dying for me to come through each of them in great detail. I'm just going to give you one quick example of one of the most characterized mechanisms, which is anaphase lag. So anaphase lagging is essentially the failure of a single chromatid to be incorporated into the nucleus, so resulting in the monosomy of that chromosome. It occurs when that chromatid fails to attach to the spindle, or when the chromatid attaches to the spindle but just fails to be incorporated into the nucleus. So that unincorporated chromatid often forms its own little micronucleus, which typically just degrades over time. So in this little cartoon on the right of a cleavage stage embryo, the abnormal mitotic event, which in this case was anaphase lagging, occurred during, cleavage stage division. And then the resulting blastocyst has 2 karyotypically distinct cell lines. So we see euploid cells, and we also see monosomic cells stemming from that monosomic cell that resulted from the anaphase lagging event. I'm going to show you this really quick video where we start with a euploid cell, and the chromosomes are labeled in green and the mitotic spindle in red. And during cell division, you see the chromatid that gets left behind during segregation and forms a micronucleus. Let me see that. There it is. And so to me, this video is just super cool. So you start with this euploid cell, and now after mitosis, there's 1 euploid cell and 1 aneuploid cell. So we actually visualize the making of mosaicism. So what what do we know about mosaic embryos? We know that mosaic embryos can implant. We know that next-gen sequencing is sensitive enough to detect mosaicism in small cohorts of cells. And we know that it can estimate the percent aneuploid cells in that biopsy sample, as well as characterize the kind of abnormality in that biopsy piece. Published guidelines by Cogin and Pgta currently state that anything with putative 20% abnormal cells or less in the biopsy sample should be treated as normal. Greater than 80% abnormal should be treated as abnormal, and everything in the middle should really be treated as mosaic. So is a trifecta biopsy a reliable predictor of the remaining embryo? And this is obviously a hugely important question. So we know that a blastocyst biopsy is taken from a random sample of trifecta tissue, which is destined to become a placenta. So when talking about mosaicism and the ability of Pgta to detect it, it's really important to review these two scenarios, global mosaicism and intra-biopsy mosaicism. So in the case of global mosaicism, this scenario can lead to false Pgta results. It works on the scale of a blastocyst and does not get detected from a trifecta biopsy. So the result is not an accurate snapshot of the remaining embryo. And this embryo, for example, could then be wrongfully diagnosed as full and uniformly aneuploid and simply discarded. The good news is the case of global mosaicism appears to be very, very rare in instances of whole chromosome aneuploidy. So there's been some studies now that have shown that when a trifecta biopsy displays a fully aneuploid result, over 97% of the time the ICM is also aneuploid. I should mention that segmental aneuploidies, however, are definitely significantly less concordant, and the jury's still out on what and how to handle these, but it seems like we shouldn't be discounting them just yet. So in instances of intra-biopsy mosaicism, on the other hand, the mosaic composition is captured by the Pgta result in the trifecta biopsy, though we still don't necessarily know if the percent aneuploid cells or the aneuploidies present in the biopsy truly represent that of the remaining embryo or the ICM. And PGIS and Cogin say in the absence of a euploid embryo that mosaic embryos can be transferred. This is based on studies showing that mosaic embryos do or can lead to seemingly healthy births, although at decreased implantation rates. So I think I might be running out of time, but I just want to gloss over the prospects of non-invasive Pgta. So even though studies have shown that trifecta biopsy does not affect embryo viability, it's still a very labor-intensive process, and that also means expensive. So it's one reason people are evaluating non-invasive Pgta methods. So let's start with just looking quickly at spent culture medium. This is essentially collecting and evaluating the medium that the embryo is cultured in and evaluating that medium for ploidy. So it's trying to look at cell-free DNA derived from the embryo, although the mechanism by which this is derived is still really unknown and not well characterized. But right now the results are kind of mixed as far as concordance between trifecta biopsy and spent culture media. But we might not need a one-to-one substitute of trifecta biopsy. So maybe there's a place for a low-resolution screening tool for labs that don't perform trifecta biopsy. But people are still kind of refining this technique, and who knows? Maybe one day it will replace trifecta biopsy entirely. But for sure, it's a rapidly evolving field, and if successful, I think will definitely revolutionize Pgta. So there's also groups that are working on blastocentesis, which is using the blastocele fluid to evaluate embryo ploidy. So the way that can be done is you can extract that blastocele fluid by inserting the ICSI needle and just aspirating it out of the embryo cavity. And then this fluid is essentially what's used to evaluate for ploidy. So blastocele fluid alone has kind of displayed mixed results as far as concordance with trifecta biopsy is concerned from different groups. But there are groups that have reported pretty good concordance between trifecta biopsy when they compare it to a combination of spent culture media and blastocele fluid. So when they pool those two things together. And then last on my list of non-invasive methods is, last but not least, is morphokinetics and time-lapse. So some studies have shown that embryos exhibit different kinetic behavior in cell division patterns, according to their ploidy, and others have really refuted that claim. Some are looking at a correlation between morphokinetic patterns and implantation potential rather than strict ploidy status. So this may not necessarily replace Pgta, but could instead offer kind of an added benefit to perform in parallel. So just kind of quickly sum things up. Still heated controversy on the efficacy of Pgta, but it's likely here to stay. Biopsy, usually of the trifecta. Diagnosis is predominantly by NGS, and higher resolution platforms have really provided us new insight and given us a lot to think about, and probably moving forward, only more things to consider. There's great promise for non-invasive Pgta, especially spent media. And who knows, maybe one day every embryo will undergo some form of Pgta as a snapshot for the overall health or implantation potential of an embryo. And with that, yeah, thank you everyone.